Good afternoon, everyone, and welcome to the CMHSR seminar. I'm Byron Powell. I'm the co-director of the Center for Mental Health Services Research, along with Leo Cabasa. And we are so lucky today to have Dr. Jessica Schleider with us. Dr. Schleider is an assistant professor in the Department of Psychology and Clinical Psychology program at Stony Brook University. She serves as faculty affiliate at the Alan Alda Center for Communicating Science, and was an academic consultant to the World Bank's Education Global Practice. Dr. Schleider completed her Ph.D. in clinical psychology at Harvard University in 2018, along with a doctoral internship in clinical and community psychology at Yale School of Medicine. She graduated with a BA in psychology from Swarthmore College in 2012. And her research is on brief, scalable interventions for depression and anxiety in young people, which has been funded by the NIH, NSF, and HRSA, and recognized via numerous awards, including the NIH Director's Early Independence Award, which is a big deal. So excited to have you highlight that work today, Dr. Schleider. She's also received awards through the Association for Behavioral and Cognitive Therapies, including the President's New Researcher Award, and the Society of Clinical Child and Adolescent Psychology's Abidin Early Career Award. Her work has been featured in The Atlantic, Vox, and US News and World Report, amongst others. And in 2020, she was chosen as one of Forbes 30 Under 30 in healthcare. Dr. Schleider's published more than 70 peer-reviewed articles and book chapters, and has co-created 5 open access single session mental health programs, which have served more than 7,000 teens and adults to date. If you're on Twitter, you may have seen Dr. Schleider on Twitter. And one of the things that I always appreciate is just your generosity of spirit and sort of your approach to open science and helping others out, as well as just your vulnerability about the challenges of this work. And so really appreciate you and excited to learn more about your work. So join me in welcoming Dr. Schleider. We ask that you would save questions for the end, and hopefully we'll have 15 or 20 minutes towards the end of the session for questions and discussion. Thanks so much for joining, and welcome, Dr. Schleider.
Thank you so much. I'm really excited to share what our lab has been up to with all of you. I'm just going to share my screen. Hopefully this is the right screen. Does that look correct to folks? Okay, I have 2 monitors, so I'm never quite sure what comes up for people, but great. All right. So just to quickly start off, none of this would be possible without a lot of people believing in the idea that single session interventions might be useful. So we're very grateful for the funding we've received that makes all of what I'm going to talk about at all possible. Okay, so like any good cognitive behavioral therapist, I'm obliged to start with this agenda here. So I'm going to begin with a background and overview of really why our lab does the work that we do and why we think it's important and potentially helpful. I'll discuss the promise of single session interventions, which remain a relatively new still idea within clinical psych and mental health more broadly. I'll share our most recent trials building and testing SSIs for youth and for parents, and share our ongoing efforts and upcoming projects designed to expand and disseminate the SSI repertoire using various different kinds of partnerships to leverage the power of multiple systems at getting these out there. So I'm certain I'm preaching to the choir with this particular slide, but there has been a lot of incredible progress in identifying effective youth mental health interventions. And at the same time, we have an exceptionally long way to go before meeting the needs of youth across the country. In the US, of the kids who experience mental health difficulties warranting treatment, about 20% will access any kind of specialty service within a given year. And of that 20%, only about 1 in 5 ends up receiving what evidence-based therapies would consider to be a full course or dose of treatment. To unpack that a little bit more, Meta-analyses show that the mean number of sessions that are included in evidence-based treatments for youth mental health is between 14 and 16. National insurance reimbursement data tells us, however, that the mean number of sessions youth go to in community mental health centers is less than 4. And data from the US, the UK, Australia, and Canada suggests that the most common number of sessions that youth end up attending in specialty mental health care settings is 1. Provider shortages are, of course, a big driving force in why these numbers persist. However, provider shortages as they currently exist in the United States are simply too severe on their own to fix this access to care problem through workforce expansion by itself. This map is generated from HRSA publicly available data showing mental health care provider shortages a few months ago in the US. The blue areas are designated shortage areas for mental health care providers. You'll notice the whole map is blue. That's not an error, that's just the state of things that we're up against right now. More bad news before I get to some hopeful news. In temporal meta-analyses, looking at effects of youth mental health treatments over time, we actually see that if we combine and pool those effects, we haven't gotten that much better at treating mental health problems. Our best treatments don't always work. And in the case of depression in particular, we've actually seen a significant decline over the past 40 years in effect sizes we see in clinical trials for youth depression. So hopefully this gets us all on the same page that there's a real need for accessible and well-targeted approaches that both can augment the effects of the interventions we already have and offer something with scientific support, ideally, to those who would otherwise access nothing at all. And I want to emphasize too that nothing is not necessarily better, or something is not necessarily better than nothing. We need to make sure that the something is actually incrementally better than nothing at all. So hopefully that's where our lab can help come in. The Lab for Scalable Mental Health aims to develop brief and scalable interventions for youth mental health problems to figure out how they work and who they can benefit most to boost personalization and matching to brief interventions, and to test all the ways we can think of to disseminate these supports that are designed for scalability beyond traditional brick and mortar clinics, which is amidst the COVID-19 pandemic become all the more critical. And I want to emphasize before I continue on the SSI single session intervention sort of marathon that we're going to go on together. I do not want, nor do I think SSIs should replace anything that is already in place. The reality is our current mental health care ecosystem for young people isn't going to cut it. It is not enough. And it never will be in its current form. So we need to figure out how to plug these gaps, to bridge these gaps that exist and that have persisted using innovative, creative strategies. And SSIs can hopefully be part of that solution. But this is a synergistic suggestion, not certainly suggesting that they should replace treatments that already exist and are already in place. So the first question to ask, right, in pursuing research on single session interventions is, can they actually do anything? And this was a question that I asked myself repeatedly as a graduate student when I was working in community mental health settings and kept seeing folks come once and never again, not because they didn't want to, just because it wasn't feasible. There were too many logistical barriers. So I started wondering, purely out of frustration, is there something I can do so I know that if they only come once, I at least help them a little? And as it turned out, I was not the first person to have that frustrated thought. Back in 2016, when I conducted this meta-analysis, there were already 50 randomized controlled trials of SSIs for youth mental health problems with an overall significant positive effect compared to respective control conditions. These effect sizes are what emerged for particular problem types. You can totally ignore that eating disorder effect size. The confidence interval is enormous. But what I do want to highlight here is this comparison. The red bars there are mean post-treatment effect sizes for multi-session youth mental health treatments, on average 16 sessions. The blue bars are post-intervention effect size for the same mental health problems in young people for one session treatments for the same problems. And my advisor and I were convinced I had done something horribly wrong because this can't possibly be true, but it is. And from a glass half full perspective, because why not go that way? This means that there's something we can do with single session approaches. We may not have a clear sense of what that is yet, and that's part of what our lab is trying to figure out, but leveraging the potential of making change in a brief period of time seems like an actual real possibility. So of course, that begs the question of, if you only have one session, what should you do in that session? And that's the question we think about a whole lot. And we take the approach of attempting to target within a single session, but within person beliefs or behaviors that have some chance of being modified in a short period of time. Either short-term mechanisms like a sense of hope in a young person or parent accommodation of child anxiety behaviors, or specific symptoms like withdrawal from activities or self-hatred, rather than very multifarious syndromes like major depressive disorder. And hopefully targeting these proximal factors can underlie or spur long-term change. And we're exploring these possibilities in the context of multiple different interventions, primarily focused on digital interventions, since those are much easier to scale, particularly when self-administered. And we're trying to see what we can do by addressing these targets, both in the shorter and the long term across different settings. And what I'd like to do now is kind of shift into some of our work focused on adolescent depression. This is the work that's funded by the NIH Early Independence Award. It's kind of high risk, high reward research, which I suppose makes sense for this kind of work. So to date, we have found that 2 different types of single session interventions have promise in reducing adolescent depression. One of them is something that our lab calls project personality. It teaches malleability beliefs, the idea that depression, anxiety, and related features and characteristics are inherently malleable because of neuroplasticity. All of us have potential for change. It's built in, whether we like it or not. So things that feel permanent may not be as permanent as we think they are, like depression and anxiety. So that's targeting a sense of hope, a sense of perceived control over outcomes that often is absent in depression. And we found in multiple trials that this, I am not sure what's going on. Hold on, this is confusing. Sorry about that. I think closed captioning.
No worries, and let us know if it's something on our end.
No. All right, I'm just going to keep going. So we found in multiple randomized trials that this intervention can be helpful, both compared to active controls and compared to different interventions for youth with elevated symptoms and for community samples in schools. And that's with follow-up periods of 3 to 9 months. There's also evidence that a behavioral activation SSI approach can be effective. Previously, this was primarily examined with older adolescents and college students with face-to-face delivered interventions rather than digital, but there's some evidence that self-guided activities teaching the basics of behavioral activation and helping people develop an action plan can actually produce symptom reductions. So during the pandemic, when it hit, our lab was very eager to figure out what we could do. We had these interventions that seemed right for the moment to be scaled and to be disseminated. And so we kind of wrote this supplement grant for the DP5 award in a weekend and ended up getting it to conduct a nationwide clinical trial of 2 different SSIs for adolescent depression, Project Personality and the ABC Project, to see if they could reduce depression symptoms and a host of other negative mental health outcomes in a nationwide sample during the middle of the pandemic. These results were recently published in Nature Human Behavior. Our data are all public, as are our code. So if you're interested in any follow-up analyses, sorry, my room's eco-friendly and it thinks I am gone. Feel free to use the data. So we had 2,452 adolescents ages 13 to 16 in our clinical trial. We recruited them entirely on Instagram, using some ads that our team worked hard on and co-created with some adolescent participants. And we were able to recruit this sample because we obtained a waiver for parent permission or parent consent. through arguing that it's the ethical thing to do. These interventions have been established as not harmful and potentially helpful. And in circumstances such as the ones brought on by COVID-19, where most people were cut off from the services they were normally getting, this seemed like a logical thing to make available to as many teens as possible. And they went for that. So we were able to recruit directly to teens. 87% met clinical cutoffs for depression. We've specifically recruited kids with subclinical or higher symptoms to get some variability there. Also, because subclinical symptoms can still be really difficult to deal with. Most were female, and actually 80% of our sample was sexual minority youth, and 20% were gender diverse youth. And around 50% were racial and ethnic minority young people. And I'll talk about this more later, but I'm very confident in some of the qualitative data that we've collected from teens that this had everything to do with waiving parental permission. Yeah, happy to talk about that more later. This is just a map of where our participants were. It was exciting for us to see, and so I wanted to share it. So very straightforward RCT design here. Teens completed an online screener. They were randomized by a survey into one of 3 20 to 30 minute single session interventions, one of 2 active programs, or a control program. I'll talk through all of those in a moment. We assessed immediate pre to post intervention changes in those proximal factors that we try to target, like hope, perceived control, agency, things that we know from other studies that we've done actually predict the magnitude of longer term outcomes. And then we looked at 3-month follow-up to see if changes in symptoms happen differentially for conditions. And now I just want to share our overall approach to actually building single session interventions that are digital and self-guided for youth, and what they looked like. So we've labeled our general approach, which draws from social science, communication studies, marketing research, you name it. We've drawn from wherever we could to figure out what are the elements that may be useful if you only have this very limited amount of time to focus on. And here's what we have identified for adolescent-focused interventions. One, we use brain science to normalize the concepts that we're teaching and to strengthen youth buy-in. Teens are skeptical, which is great. We want to encourage that. They also are not inclined to believe random adults who they've never met who say they're right because they're right. And I learned this actually before I went into psych. I taught middle school math. So that's honestly where this insight came from originally. And so we use brain science to normalize the ideas that we're explaining and say, look, it's not just us saying this, it's just how your brain works. We can't help it. E is for empower. Often youth are actively disempowered in the mental health care system as it exists today. They don't have a lot of agency in seeking out different supports. Parents are typically gatekeepers. So there's a lot of efforts to empower youth and center their opinions and ideas. We include saying as believing activities to solidify learning, which is essentially asking teens to give their best advice to others. And testimonials and evidence. So we've collected stories over the last 5 or so years and update them periodically from teens with lived experience of depression and anxiety about how these skills have been helpful for them in their actual lives. So these are just the first things that teens see when they start the interventions. As you can see, they are framed not as, here's something to help you, but as, hey, we need your help. We describe ourselves as scientists from Stony Brook, and we study all these things from brain science to how people change, to how people cope with stress and depression and all these things. But we're out of touch and we don't know how to talk to teens. So please help us. You do know how to talk to teens as a teen, and you know how to deal with these problems that you're facing. So we would appreciate if you would help us out to communicate these ideas. These are just a couple of examples of the ways in which we use brain science concepts, very simplified versions, to explain basic concepts in why behavioral activation works or why people are capable of change. So, we emphasize the ideas that everyone's brain is a work in progress. We also highlight ways that brains can get it wrong and get into patterns that actually don't help us and, spur us into avoidance cycles of unhelpful behavior. To give them more insight into why things are happening the way that they are. They listen to and also read the testimonials and narratives from other teens that I mentioned before. And all of the text is audio recorded for teens in case they have difficulty reading. For the behavioral activation program, we also include a personalized action plan. We ask teens first to rate their mood. How are you feeling on a 0 to 10 scale? They then can pick one of 3 amazing, wonderful videos to watch. This one here is a teddy bear, the porcupine, eating a pumpkin on Halloween and making fantastic noises. We've piloted many videos and this one rose to the top. That was a fun time. And then we ask for their mood again. And if their mood doesn't go up by at least a point, which some of them are kind of defiant and are like, no, I got worse. Then we, reroute them to other videos until they say, okay, I kind of feel a little better. And then they have a built-in piece of evidence suggesting that doing something positive for a minute can actually impact how you're feeling. Imagine if you made a plan intentionally and scheduled things in your life and prioritize things in your life that you actually value and care about, how much that would do. So we have them build an action plan, choosing ways to connect with people, achieve a goal that matters, and do something they enjoy just for themselves, when they're going to do it, how they're going to overcome roadblock thoughts to doing it, and who's going to help them do it. Saying is believing activities, we literally ask teens, okay, now we're collecting advice from you to give to other teens, which actually is filtered to other teens because we have a public advice center on our lab website that we update with teen advice periodically. So in project personality, we ask teens based on what you learned about your brain and our ability to change, what advice would you give to a peer who felt rejected by someone they thought was a friend? We got wonderful responses, and in the ABC project, we asked based on what you've learned about reversing negative mood spirals, what advice would you give to a peer who felt stuck in a low mood? And I'll just read one because I like it. It's okay to have bad thoughts and feel awful, but remember they're just thoughts. Start by doing small things, then move up to bigger things that make you happy. You can do more than your brain says, and people who love you are here to help. Teens are very good at giving advice, especially because they've been there, and the feedback sessions we've had with youth suggest that this is their favorite part of the program. What is our control group? This really matters because we don't want to just compare it to absolutely nothing. We wanted to really be sure that the mechanisms that we're targeting in these brief interventions are the things that are useful. So we've created and have used in multiple RCTs to date a sharing feelings control program, which is a 30-minute single session intervention that's designed essentially to be as close to supportive therapy as you can get in a digital SSI format. It controls for non-specific aspects of going through an online activity that's interactive. It tells teens that they should share how they're feeling with people. It doesn't give specific skills. It just says, here's a positive thing that we think would be helpful for you to do. So it resembles advice kids often receive when we ask, do you think you were in the new intervention group or the control group? They guess incorrectly, or it's like 50-50. There's no mention of malleability of personal traits and no chance to give advice to others, but there are the same number of writing activities and all of the interventions and interactive elements to match on that feature. Okay, what did we find? Just going to wrap this up in a nice bow. So first we looked at immediate intervention effects because we know from prior trials that those are important, both for the theory behind why we're doing this and potentially for forecasting longer term outcomes. What we found was that both of the interventions significantly improved levels of hopelessness from pre to post intervention compared to the control. And both of the programs also significantly improved perceived agency from pre to post intervention compared to the control. By perceived agency, I mean ability to solve problems that come up for you in everyday life. What we cared most about was our 3-month outcomes. Do these things have sustained impacts over and above an immediate boost, which can be helpful on its own, but we do care about the long term as well. Yes, so both interventions outperformed the control in reducing depression symptoms from baseline to 3-month follow-up. I want to note that all 3 interventions, including the control group, had medium and significant within group effects on depression. That is, everybody got better. Everybody got better over time. And this was not an inert control. It was a very active control. And so the fact that we still saw these small effects was exciting, especially given a sample of this size where we would expect most things to null out. We also found that project personality, but not the ABC project, significantly reduced anxiety symptoms and COVID-related trauma symptoms from baseline to 3-month follow-up. And we found that both interventions significantly improved levels of restrictive eating over the past 3 months, which we were not expecting, nor did we predict. But I'm very fascinated by this outcome and definitely excited about the prospect that these kinds of programs can be helpful for disordered eating behaviors as well. So one question that we had in the grant, for whom do these interventions work best? So one of our graduate students, Riley McDaniel, led a really wonderful study on this recently that we're writing up now, but she wanted to see whether demographic factors like race, sexual orientation, and gender identity had any impact on the magnitude of the intervention effects, primarily because there's some evidence that other evidence-based treatments are underperforming for minoritized and marginalized young people. I'm not going to detail the approach because we have a lot to get through. Happy to talk about the EFA-derived latent internalizing model if you'd like. But what we found was that nothing predicted outcome demographically, which was really interesting and also somewhat exciting because this tells us that we're not underperforming for youth who are often not served quite as well by the interventions that are available. And particularly given the broad accessibility of this intervention, it's good to know that folks who are often missed entirely by the mental health care ecosystem may have something that can be supportive in the moment. I also was excited about this finding because we were actually able to look at different subgroups independently rather than creating a binary variable for minority versus majority, because there was such good representation of gender diverse and sexual minority and racial and ethnic minority young people. So overall, we found in this trial that compared to an active control, 2 different SSIs strengthened perceived agency and reduced hopelessness, reduced depression symptoms over 3 months, reduced restrictive eating over 3 months, reduced generalized anxiety and COVID-related trauma symptoms in one of the programs, and that these effects didn't differ by race, ethnicity, sexual orientation, or gender identity in a sample of almost 2,500 young people from all 50 US states. We're very excited about these findings, and I'll tell you about where we're bringing them next in just a moment. But before I do, I also want to share some of the work that we've been doing targeting parents who were entirely absent in the trial that I just discussed and are an absolutely critical factor in getting youth access to mental health services. One avenue that my lab had been interested in going down relevant to this is an intervention targeting parents of much younger children, targeting risk factors that might contribute to longer term likelihood of onset of anxiety and later depression. We came across some really exciting work from Ellie Leibowitz and Wendy Silverman over at the Yale Child Study Center on a new intervention that was provider delivered multi-session that they had developed and evaluated called the SPACE program. And the SPACE program is a parent-only intervention for child anxiety disorders that has shown non-inferior effects on child anxiety disorders to exposure therapy. And it does that by targeting and helping parents to reduce the level of accommodating they do for child anxiety. They essentially train parents to be exposure coaches for their kids without involving the kid in treatment at all. We wanted to see whether we could target parents' accommodation of avoidance and anxiety behaviors in a single session to any degree, particularly in a digital format. So my graduate student, Jenna Sung and Emma Mumper led the development of Project Empower, which is a single session approach to teaching parents to promote bravery and reduce accommodating behaviors for anxiety in their kids. So we wanted to see whether this program was acceptable, whether it actually reduced parent accommodation, and whether it improved parents' ability to tolerate distress, given that that's a main factor in why parents accommodate in the first place. They see their kid in distress, they want to rescue and make the distress go away, so they save, right? So this was in a sample of 300 parents from across the US, and it was a pilot trial, so it was the first study of this intervention. You can see we start off the same way. We tell parents that we are working on making resources for people like you who maybe are anxious and are worried that their kids might be anxious. And we specifically in this study targeted parents with elevated anxiety symptoms, since we know that anxiety is so heritable. And we just said this is for anyone who interacts with kids, and please help other parents by thinking through these things and offering your perspectives. The main goals of the program are to help parents identify situations that trigger kids' avoidance instinct. So not using the term anxiety, just to ensure that everybody relates to it. We teach parents to empathize with their child's instinct to avoid and understand that it makes sense from their perspective to avoid something they see as scary, and to encourage their their kids to approach that scary seeming thing anyway when there's no real danger, because they can do it. And they literally make a plan of a script, like what to say when child encounters X, Y, and Z triggers that come up for them frequently. We normalize that parents are going to become distressed as they're doing these things, because it feels very natural as a parent to swoop in and stop any distress in kid when they see it. And that distress, even though it makes sense, is actually taking an opportunity away from their kid to learn that they can actually cope maybe a little better than they think they can. So we also differentiate for parents between accommodation and accommodating and attentive parenting, which is a really tricky distinction because accommodation often feels like what a good parent should do. So we wanted to make sure to address that difference for parents. So in our 300 sample, we found that parents who completed Project Empower rated it as highly acceptable on all the metrics that we used, which are standard across all of our SSI approaches. When we asked, compared to before you started this study, how prepared do you feel to help your child manage the stress? 84% of the Empower plus information group said, I feel a little or a lot better about helping my child manage distress. In a group that got just information, as in links to many evidence-based websites about how to address child anxiety, only 21% said they felt a little or a lot more prepared. We had a 2-week follow-up in this study because it was initial. We're now conducting a larger trial, but Project Empower significantly reduced parent accommodation of child anxiety from baseline to 2-week follow-up, and significantly improved parent distress tolerance over 2 weeks compared to an information-only control, suggesting that this may be a more helpful option than just giving parents handouts about what accommodation is and how it works. This intervention has now been translated into Spanish and Haitian Creole and culturally adapted for folks from both of those settings. That's in a collaboration with Jill Erin Reich-May at University of Miami. And we're finding similar effects, both on the acceptability and the longer term fronts in different populations of parents who we thought would have different needs, and turns out they don't really, at least not as much as we thought. So where are we going now? Our current and next steps are collecting a lot more data to learn for whom can these interventions actually be the most helpful. The reason, or one of the main reasons I think that we haven't really gotten at that question in clinical trials research is because our samples have been so constrained and so unrepresentative of the youth we're trying to serve. So we're hoping to change that by using and leveraging the scalability and the possible for large scale data collection that SSIs create. We're testing many different dissemination models to learn where they should live in the mental health care ecosystem, what is the least resistant path to getting these things out there. And we're continuously attempting to center youth voices in refining these programs and in designing them in the first place through co-design sessions and focus groups, and helping and asking youth and inviting youth to actually contribute content to the interventions themselves across different kinds of programs. Okay, so we are a very young lab. We're 3.5, so like toddler stage. And it's escalated pretty quickly. So right now, in the past 3.5 years, we've completed or are in the process of completing 18 trials of single session interventions, looking at online direct to youth dissemination strategies like the trial I shared initially, outpatient clinics, so for people on therapy waiting lists, which we know can be incredibly long, to help prevent deterioration, and via primary care. So in the Stony Brook pediatric primary care system, we routinely screen for depression symptoms in youth, and we have nothing to give them if they screen positive, except for maybe a list of referrals to providers who have 6-month waiting lists. So we're trying to see through a foundation-funded grant if we can improve that by offering folks SSIs. We've reached over 7,000 folks with our SSIs to date. All of them that are digital are fully translated into Spanish, thanks to a partnership with the City of San Antonio's Public Health Department. We have funding to tailor our SSIs for LGBTQ teens with support from the Upswing Fund, and we're just gearing to launch that website very soon, which will be called Project Restore. Oh, sorry, come on. Okay, it'll go eventually. And as is very important to us, we care not just about access to the interventions themselves, which is why we make the programs freely available, but we also care about access to the science behind the interventions to enhance replicability and continued exploration of these kinds of effects. So all of our de-identified data are publicly available for anything that I've talked about today. So I want to share some ongoing projects that we're working on, just to give you a sense of the scope of the different kinds of questions we're asking and the different strategies we're using. This is the single session consultation is our only provider delivered intervention that we've been evaluating, because a lot of people, specifically those people who seek out outpatient therapy services, want to talk to a person, and our digital interventions do not meet that want. So in the service of meeting people where they're at and acknowledging their actual preferences, we wanted to create another option. So we wanted to see whether a therapist-delivered solution-focused brief therapy single session intervention could reduce hopelessness, increase agency, and prevent symptoms from worsening for people on therapy waiting lists, which at our clinic, where we're testing this, are between 2 and 6 months long. People tend to get worse while they're waiting for treatment and getting nothing else. We wanted to see if we could help reverse that. I developed this really structured intervention a couple of years back using SFBT principles. This is nothing new, it's just repackaged. The provider training takes 90 minutes and we're able to assess fidelity, and that provider training plus a mock session does lead to faithful implementation of this intervention, which is really exciting. And the intervention itself is like 45-50 minutes, just like a regular therapy session. This is the whole intervention. The reason we can assess fidelity is because if they complete this worksheet and fill in the blanks with things that make sense, they have successfully done the intervention. So fidelity monitoring is very easy, which is a big plus. I'm not going to go into the details, but the main gist of the program is to help them identify a problem, a goal for the session. So what can they change from now to 45 minutes from now that could have some impact on a broader goal they have or a broader problem they have? And what is a plan they can make for getting 1 point closer on a 1 to 10 point scale towards making that goal happen? So they make the most minimal possible action plan, maximize to, optimize the likelihood that they can actually do it to increase that sense of agency. And they walk away with a clear plan on how to, make 1-inch step towards a problem that they care about. We first did a trial of this pre-pandemic face-to-face. We found that 30 clients who completed the SSC while on waiting lists showed a high chance of decreasing their hopelessness levels, 87%. They showed a 92% chance of improving in terms of their perceived agency. And they actually reported reductions in overall psychological distress symptoms while waiting for treatment on average, which was exciting to see. Then COVID hit and we were like, well, guess we should keep doing this, but telehealth, because the wait list only got longer. And we've now done this and we're writing up the results with 65 folks on waiting lists who received the SSC through teletherapy at our clinic. Again, we saw that hopelessness and readiness for change both improved from pre to post SSC, which was exciting to see. We also rated levels of therapeutic alliance from the patient's perspective, because I get a lot of questions about whether alliance is possible within such a short therapeutic format. And we benchmarked from other trials that have used the Working Alliance inventory for longer term therapies and found the identical scores for client rated alliance with a 1 session versus full length therapy. So that was exciting to see as well. Psychological symptoms non-significantly decreased while people were waiting for therapy, which kind of makes sense. COVID did make things a little more stressful. So the bottom line, though, is that we didn't see people having that typical pattern that we see on wait lists of getting worse while they're waiting for treatment. And that we consider to be exciting and certainly a win. Okay, shifting gears a little bit to some of the direct to youth work we're doing. A couple of years back, now almost 3 years back, we were lucky to get a little bit of press coverage of the work that our lab does. That had a really exciting effect of having people reach out to us about our interventions, but it also had the really overwhelming effect of having people reach out to us about our interventions. And all of a sudden we were like, we're not prepared to give this to you. And that seemed totally counter to our message. So we built something to fix it. So Project YES, which stands for Youth Empowerment and Support, is an open access program evaluation project where youth can anonymously choose from 3 different single session interventions, tell us how they like them so we can improve them. And it allows us to collect ongoing data to make sure that any adjustments we implement into the interventions are not impacting acceptability or utility. Project YES has 3 steps. Youth first try an activity. They tell us what they think of it and they share their advice. This is the advice center I alluded to earlier. So we have a whole web page of just youth suggestions for how to cope with stress. We find that youth who take part in Project YES of their own volition tend to be sexual and gender minority youth, higher proportion of racial and ethnic minority youth than we normally see in clinical trials. And we find that it's helpful for hopelessness, self-hate, perceived control. The acceptability and effects, as in the larger trial I presented before, don't differ by gender identity or sexual orientation, so we're not underserving youth who are chronically underserved. In a partnership with San Antonio, Texas, their health department, we were actually able to test Project YES as a citywide resource through a service grant that they provided us with. And we essentially replicated all of the effects that we found in the online only trial. And this was through community-based dissemination only, rather than using social media. And primarily with youth who weren't seeking services, who were in schools and things like this. So we're really excited to be writing up those results soon. Both the Spanish and English version showed similar effects in acceptability, which was very exciting. Other ways we're trying to streamline dissemination. We recently got a grant from HRSA focused on reducing burnout and improving resiliency in healthcare workers and trainees, which is someone married to a medical resident who's been a resident for the whole pandemic. Very close to home, very excited to work on this project. And we're actually going to be building what was like an imagined idea when I first started this job that I assumed I would do maybe in like 40 years. We're building a walk-in clinic for single session supports that will be available at no charge to healthcare workers and trainees at Stony Brook University. We're going to establish the center, which will offer both digital and our single session consultation approaches anytime and remotely if folks want. The therapists will be graduate student trainees at Stony Brook to ensure sustainability, and they'll be built into training programs at Stony Brook as well. And we're excited to do this and co-design the sessions for the healthcare workers. I want to leave time for questions, so I'm going to kind of like skim a few different things. We have an SBIR, a Small Business Innovation Research Award with Jill Ehrenreich-May and 3C Institute to develop the unified protocol, which is of course a provider-delivered evidence-based treatment for youth emotional problems, into a youth-directed open access kind of platform where they can select modules from the UP to try out on their own. And we're in the midst of the design stage of this, and it's a lot of fun. We're also experimenting with social media partnerships. So there's a company called Coco, or a nonprofit called Coco that works with Tumblr. And we've been collaborating with both Tumblr and Coco to see if we can embed our digital SSIs into Tumblr. So that youth who search for terms like depression or mental health or help or treatment can actually be funneled directly into the interventions at the moment that they are searching for help. And we've adapted 2 interventions that we've developed for the Tumblr format. One of them is the ABC project, which I mentioned before. And so far, in the first almost 1,500 users, we've been able to replicate the effects we've seen in Project Yes when we are paying for advertisements through social media. So again, we're excited to continue this work and seeing how far we can push it and where its limits are. Lastly, we're working in many ways to center youth's perspectives in intervention design. And just one point that I want to focus on are some of the barriers that teens have been sharing with us about what gets in the way of accessing care when they need it most. And what we've been able to glean from this research in several different samples at this point is that waiving parent permission really matters. When we asked teens who wanted mental health treatment but couldn't get it, what got in the way of getting mental health care when you wanted it, about 1/3 of all the barriers they identified were their parents. Feeling unable to communicate about mental health with their parents, knowing that their parents wouldn't respond well, fearing disclosure to family members, knowing that their parents wouldn't be supportive of the reasons they wanted help, especially when they were identity related. Financial concerns in general, stigma also contributed, but the parent piece is really critical. And we also found that youth with minoritized identities were more likely than non-minoritized youth to endorse parents as barriers to treatment. So this is not to say that we should exclude parents from services, right? It's more to say that we should have flexible options so that youth who need help can seek something safely when they need it through the channels that are available to them in the moment, while also on other fronts addressing the need to increase communication and mental health literacy in families across the country. Okay, I think I'll stop there. Thank you for your attention. Here are links to all our interventions. Here are some of our great lab members who did everything. Yeah, happy to take questions.
Thank you so much, Dr. Schleider. That was incredible and an amazing amount of work in 3 years or just over 3 years. I know it's a long time building up to that with your doctoral work and whatnot, but this is really impressive. So thank you for sharing. Folks, feel free to ask questions in the chat or feel free to unmute. I might start off with sort of a broad question, but I'm curious about, you mentioned sort of, you know, the lab growing and getting requests as your work has received attention. Do you have any advice to new investigators or even mid-career investigators that are building labs or are considering things like open science, like I mentioned in your intro? It seems like you've done a lot of work to sort of build the infrastructure for that in your lab. So any thoughts on how you've done that and how you've managed that over time as demand for this work grows?
Mm-hmm. So I think the key has been working really hard up front to creating sustainable systems that can operate regardless of who's in the lab at any given time. So things like having a really clear pipeline for pre-registration. So we have templates that folks can recycle when pre-registering studies, so they don't have to reinvent the wheel every single time. We have a lab manual with really clear expectations for what goes into a study and, you know, what pieces need to happen in what order, how collaborations work, things like that. In terms of setting up for broader, you know, dissemination and collaborations, I don't know if I have the best advice. I'm kind of doing the best I can. But really what I've learned is to be much more flexible and creative in the how of getting interventions out there. I've learned in many different ways the huge value of partnering with different sectors, well beyond academia, which I think is a big shortcoming of where our field has been for a long time, in thinking about structures that are sustainable for getting these things into the world. But yeah, I don't know if I have great advice, although anyone who wants to talk about lab management, I'm happy to have like a one-on-one because there's a whole system, but it took a long time and many mistakes to put together.
That's helpful. Thank you. Dr. Bauman, I see your hand up.
Sorry, hi. Dr. Schleider, I am a fan of your work. I follow you on Twitter and I've been following your work. And I just want to say that I'm here cheering you on the sidelines because I think you're going to change the health system in many ways for positive. So I just want to put it out there that I'm a fan of your work.
Is that the end of your question?
Yes, done. It's not a question.
Favorite question ever.
Yes. As you were talking about the demographics of your sample, have you been capturing, or has anyone, the system in terms of chronic disease and cognitive impairment? And that's one question, and then I will follow up with perhaps an invitation. I don't know.
Yeah, so we do in a few of our data sets ask about chronic illness, and especially in the context of COVID, that was really important to assess to see if that's, an added factor in either response or barriers that folks are experiencing in seeking out treatment. It's so much data to get through. If you want to look at it, please let me know. But we do have quite a bit of data on comorbid health conditions, and it would be very possible to explore whether that had any impact on treatment outcomes. And your other question, your other variable that you were interested, can you remind me?
Yeah, so similar things, right? In terms of both at the teenage level and also the parents level.
Yeah.
Right? Parents of kids with comorbid, yeah.
Yeah, we in studies where we actually include parents, we do ask parents for that information as well about themselves. We also have, we collect zip code data for everybody. So we have a really large, broad access to neighborhood level factors and access to healthcare services in the area that we've been unpacking in many different ways to see if things like provider shortages or healthcare provider shortages in the area have any impact on barriers to access or intervention usefulness or anything like that. So there's a lot we can do with zip code data. It's a little parallel to your question, but I think there's a lot to be found.
Very cool. I was following your work. I will keep following your work. Learning from you. That's awesome. Thanks.
Great. And I see a number of other questions. Sorry if I'm getting these out of order. Is it Najwa? If you could unmute.
Yes, it's actually Najwa. Yes. Thank you so much for this discussion. My name is Najwa Walden, and I'm a third-year Ph.D. student in the Brown School studying the psychoneuroimmunology of premenstrual syndrome. And so I'm super interested in your work, but my question pertains to whether or not you identify people who are experiencing depression and anxiety as a symptom of another comorbidity. And if you do identify those folks, how do you manage the passover or handoff for them to seek additional care to be able to address those symptoms and whatever underlying disorder they're experiencing?
It's a great question. For a couple of reasons, we keep it entirely broad with respect to who can participate in our studies, especially when we're recruiting teenagers. So depression symptoms are so common and can happen for so many reasons that we don't claim for a second that this is characterizing any particular subset of teens experiencing depression. What we're more interested in is, as a sort of public health tool, can this at scale help reduce on average depression symptoms at the population level, knowing that there's going to be huge variability in why people are experiencing those symptoms? So that's what we're really interested in. But I think the factors that you're pointing to, which are really important, are there subgroups for whom the depression focus of the interventions themselves may not be helpful because that's not the cause. And that's one of the things that we're actually exploring. So as part of our DP5, our Early Independence Award projects, we're actually collecting ecological momentary assessment data from teens to see if we can predict who responds to which single session interventions based on which depression symptoms actually matter for them, and sort of the structures of their own personalized symptoms. Super excited about that work. And with respect to the handoffs, it's tough because most of the teens in our studies don't have access to anything else. And so the handoffs come in the forms of, here are resources that you can access without parent permission and with parent permission. People can request to follow up with us if they feel like they're unsafe. We also have developed an electronic safety planning tool so that if they're in imminent risk, they can do something right away to help themselves. But unfortunately, the handoff is almost always impossible because of the factors that led to us developing the interventions, especially when we're doing nationwide studies.
Thank you. And Gretchen, you have a question if you're still on and able to unmute.
Yeah. First of all, I just want to say this is really fantastic. I am so happy to be seeing this being developed and also being scaled up so quickly. That's fantastic. I'm curious if you could talk a little more about your engagement with social media and kind of how you got started on those collaborations.
Sure. Well, that's where teens are. So we kind of had to. Yeah, it was by necessity. I mean, there was no other way to do this work on the scale that we wanted and needed to do it to demonstrate utility or to explore utility without social media. So we just kind of got going on it. We created an Instagram account. Two of my project coordinators have now started a social media research network, which includes over 100 labs across the country to share resources and ideas for recruiting and scientific communication through social media. With respect to the COCO collaboration, truly, they reached out to us and asked if we wanted to do this. So I don't have any magical solutions because it was literally, we were doing the work we wanted to do and somebody asked if we wanted to partner with them. And we were like, of course we do. People are on Tumblr. We want to have these exist where people exist. So it just seemed like a logical synergy and we've been really fortunate to have awesome collaborators in that space. But the bulk of our social media work has just been out of like, well, we have to do it this way, because that is how you reach teenagers.
Okay, so you just kind of did it yourself. You didn't necessarily kind of reach out to executives at the companies or anything like that.
We didn't reach out to anybody. Although
Cool.
now we have a connection with TikTok, and they've agreed to push our TikToks.
Nice.
Increasing visibility of our open access interventions. So we're excited about that.
You're an influencer on TikTok.
No, I do not know what TikTok is, but my lab members are brilliant at TikTok. So I'm lucky to work with these people.
Great. Well, I know we're right up against the hour, so please join me in thanking Dr. Schleider for just an amazing talk, and thanks for all the incredible work you're doing. We will continue to follow this with interest and really appreciate you sharing your expertise with us today. Just to note, our next CMHSR seminar will be March 29th at the same time, where Dr. Gretchen Buchanan will present implementation of integrated behavioral healthcare in primary care. So feel free to check that out in the chat or on the website if you want to register and attend that. But thank you again, Dr. Schleider, and hope you all have a great evening. Thanks so much for joining us, and we'll look forward to seeing you next time.
Yeah. Thank you so much, Jessica. Wonderful work. Wonderful work.
Thank you.
All right.